Nervous system, your lectures and your practicals are going on nervous system and head and neck. Now we are in the marathon's last lap, and your mock test or whatever you say, the third semester exam, third. So the whole anatomy syllabus will be given to you. Don't panic. My one word is don't panic. And please see the stomach and the esophagus and touch, feel Kodo. Now I'll go through these slides. Only 18 slides are there. Now it will be a revision for you, and also see the stomach and the esophageal end and the pyloric end. Okay. Now describe and demonstrate major viscera of the abdomen under the following headings: anatomical position, external and internal features, important peritoneal and other relations, blood supply, nerve supply, lymphatic drainage, and applied aspect. Now, the abdominal part of the gastrointestinal tract consists of the following parts: the abdominal part of esophagus, stomach, small intestine, duodenum, ileum, and jejunum, large intestine, cecum, appendix, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. This chapter includes description of the abdominal part of esophagus. Now, the length of the abdominal part of the esophagus is 1.225 centimeters. Now, course, it enters the abdominal cavity through the esophageal opening of the diaphragm, that is situated at T10 vertebral level, slightly to the left of the median plane. Esophagus makes an abrupt turn to the left from esophageal opening of the diaphragm and continues with the cardiac end of the stomach at the level of T11 vertebra, about 2.5 centimeters to the left of the median plane. The right border of the esophagus continues with the lesser curvature of the stomach. Its left border is separated from the fundus by the cardiac notch. Now, this is stomach proper, this is the esophagus. Here the stomach is entering. Now, main thing is the levels of T11, T10 vertebral level, 2.5 centimeters to the left. The length is 1.25 centimeters. Now, relations anteriorly, the left lobe of the liver, posteriorly left crus of the diaphragm, left phrenic vessels, and greater and lesser flanking nerves. Now, you have read the diaphragm. Now, structures passing through the openings. So, the vessels, the nerves, in each component, whatever the openings of the diaphragm, that's just a division. Now, what will be best is that you see the open abdominal cavity open, thoracic cavity open, that viscera, that body, dead body. Or if you have the thorax is intact and the abdominal cavity is open, then you study there. Of course, your books, tabs are there. Okay. Now, the abdominal part of the esophagus is covered by a thin layer of connective tissue and visceral peritoneum. Contains connective tissue include anterior left and posterior right vagus nerve and esophageal branches of the left gastric vessel. Esophageal ligament anchors the esophagus to the crural muscle fibers of the diaphragm and limits the mobility of the blood supply and lymphatic drainage and innervation. The arterial supply. Esophagus is supplied by numerous esophageal branches of the left gastric artery. It is also supplied by branches from the short gastric arteries and terminal arteries from the esophageal branches of the thoracic aorta. Venous drainage, there is mucosal and submucosal venous plexus in the esophagus. This plexus is drained to the portal vein through left gastric and short gastric veins and to the superior vena cava through hemizygous vein. Esophagus is the site for portacaval anastomosis. Now, this is important. Okay, lymphatic drainage, lymphatics from the lower part of the esophagus drain to the left gastric and left right paracardial nodes, and finally to the celiac nodes. Innervation, abdominal part of the esophagus is supplied by the following fibers. Parasympathetic fibers from vagus nerve. They control coordinated contraction and relaxation of the lower esophageal sphincter. Sympathetic fibers from T5 to T12 spinal segments through greater and lesser splanchnic nerves and the celiac plexus. Here, this is a nice figure. Now, this is the thoracic part of the esophagus, the phrenoesophageal ligament, the lower limb, the upper limb. Now, this is the cardiac notch, the peritoneum, the gastric folds, the zigzag line of esophageal mucus, the junction, the stomach and the esophagus meets here. This is the cardiac, at the level of the cardiac notch, subhiatal fat ring, infradiaphragmatic fascia. This is the diaphragm, and lower esophageal sphincter. This is lower esophageal sphincter. Now, the abdominal part of the esophagus, holds 1.2 centimeters long, enters through the esophageal opening of the diaphragm at T10 level, continues with the stomach of the gastroesophageal junction. Arterial supply, esophageal branches of the left gastric artery, short gastric artery, thoracic aorta. Venous drainage, left gastric and short gastric veins, portal vein, hemizygous vein, superior vena cava. Lymphatic drainage, left gastric, left and right pericardial nodes and celiac nodes. Innervation, parasympathetic vagus nerve, sympathetic T5 to T12. Now, this is important clinical integration. Site for portacaval anastomosis, Achalasia Cardia, neurological failure of relaxation of lower esophageal sphincter, gastroesophageal reflux disease, GARD, Barrett's esophagus, hiatal hernia, and esophageal stenosis. Now, this is the reflux of acid. So, continuous, and if it is treated or maltreated, then you get a Barrett's esophagus or repeated hyperacidity, and all PPI are proton pump inhibitors, these medicines are failing. Then there's a continuous, that acid gives a Barrett's esophagus, that it becomes, the squamous cells become rough and inflamed always, and there are chances of carcinoma. And by your gastroduodenoscopy, upper GI endoscopy, you can see the pathological changes in the cardioesophageal region. Second thing, if there is a loose in the sphincter there, then in the esophagus, if there is the opening that's passing to the diaphragm, there can be a portion of this fundus and the esophagus goes into the hiatus hernia. And now, esophagus, histology esophagus has the following layers. It consists of stratified squamous epithelium, non-keratinized, laminar propria, musculus mucosae, longitudinal smooth muscle. Submucosa, it consists of dense irregular connective tissue, with elastic fibers and compound tubuloalveolar gland. Muscularis externa, in the upper third of the esophagus, it has skeletal muscle fibers. In middle third, both skeletal and smooth muscle fibers, whereas in lower third, only smooth muscle fibers. Adventitia esophagus is surrounded by connective tissue, only lowest 1 inch, it is surrounded by serosa. For details, histology. Now you see the part of this. The factors preventing gastroesophageal reflux. The following factors prevent the gastroesophageal reflux. Flutter valve. The abdominal part of the esophagus is directed obliquely downward and to the left. On increase of intra-abdominal pressure, it compresses the esophagus as a flutter valve. This portion. Now, flap valve, the mucosal fold at the cardiac notch in the stomach wall acts as a flap valve on contraction of the stomach muscles. Now, phrenoesophageal ligament, it is derived from the subdiaphragmatic fascia and anchors the esophagus to the crural muscles of diaphragm. It has upper and lower limbs. It limits upward and downward mobility of the esophagus. Mucosal rosity in the abdominal esophagus acts as a watertight plug. Pinchcock action of esophageal opening of the diaphragm prevents mobility of the esophagus. Now, these can be your MCQ. The question, what is, or there will be a short note for 4 marks, that flatter valve, flap valve, phrenoesophageal ligament, mucosal rosity, Pinchcock action. Now you can see the portacaval anastomosis. The lower end of the esophagus has portacaval anastomosis in portal hypertension. This is important. Veins of the esophagus dilate and may cause esophageal varices and severe hematemesis. Now, if a patient comes with you in the emergency, there is acute pain, and also they will tell you that vomiting blood. Actually, hemoptysis and hematemesis, you have to hemoptysis and hematemesis. Presentation of the patient is that in hemoptysis, it is from the respiratory system. It is from the bronchial breathing or your lung. If there is a pathological condition of the lung, then that is hemoptysis. That is red color. But the stomach bleeding, that if it is from the stomach, then it goes to the stomach, with the acid, it breaks down and it is coffee ground color. It is coffee ground color. Like she's put your scarf, that scarf, this color, the scarf she's put on, it will be that brown, coffee brown color from gastro. Now, the severity. If a person comes with a severe vomiting within the emergency, your coffee ground color, then immediately you put a Ryle's tube and you suck and see the brown color. But hemoptysis, the quantity of blood going into the stomach then transformed into coffee ground color is a late presentation. But there will be then it will be red color, sputum red color. Never forget. And the emergency, you have to, when I have seen a patient dying in front of me, he simply collapsed. So, If anyone says, Dr. Babu, say in your routine practice, আমার মাঝে মধ্যে এরকম লালচে 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 মানে reddish, they cannot describe. But nowadays at least coffee is such, it's every person knows coffee. But previous days, coffee is very difficult to explain to the patient because Nescafe did not market in such a way. Tata did not market. Brew did not market. Only the elite class or কি বলবো বড় লোক, but গ্রামেরও বড় লোক কিন্তু কফি জানতো না. The village people who were very rich, they were not taking coffee as a drink, but they knew chai. But one thing I'm telling you, and in this type of emergency, you immediately requisition for blood, at least 2 units. You put out this thing, infusion line, if one and another one a BT set, blood transfusion set, or another IV set. Because blood transfusion set has a strainer, plastic. You have seen the tube, this thing. This is transparent, but there is a net, mesh within that thing. So if the blood immediately comes, you can directly transfuse in the blood set in one hand and the other you put it. And other anti-hemorrhagic drugs for to control bleeding. Now, of course, there are in modern days, there's GI endoscopy. There are some very good endoscopes, flexible endoscopes. Surgeons, they see the esophageal varices bleeding. They clip, so that bleeding is controlled. You don't go for a major surgery. Now the esophageal plexus, azygos vein, hemiazygos vein, the diaphragm is here. So here's the gastric veins, the splenic vein, the portal vein, and superior mesenteric vein. Now esophagus, tributaries of the azygos vein, esophageal varices, tributaries of the portal vein, and stomach. Now see, esophagoscopy is the visualization of the interior of the esophagus using esophagoscope. Here, endoscope, the light is here. Now, barium swallow in Achalasia Cardia, normal Achalasia Cardia. See, esophagus, stomach, non-relaxing lower esophageal sphincter, absence of ganglion cells in mesenteric plus bird's beak, rat tail appearance with barium swallow. Now, even though you are doing an endoscopy, but the esophagus, you have to do a barium follow. Now, Achalasia Cardia, because of neuromuscular dysfunction, lower esophageal sphincter, cardiac sphincter fails to relax. It results in mega esophagus, dilatation of the esophagus, and patient complains of dysphagia, difficult in swallowing, and in severe cases there may be a regurgitation of undigested food in the respiratory tract. Gastroesophageal Reflux Disease, GERD. In GERD, because of failure of lower esophageal sphincter mechanism, the acidic contents of the stomach enters the lower part of the esophagus. It causes heartburn, chest pain, and inflammation of the esophagus. Now, Barrett's esophagus, lining epithelium of esophagus changes from stratified squamous to simple columnar epithelium with goblet cells. The main cause of Barrett's esophagus is GERD. This is a precancerous condition. Hiatal hernia is a herniation of the esophagus through the esophageal opening. It may be sliding or rolling. Paraesophageal. Esophageal stenosis is abnormal narrowing of the human esophagus. So you see the detail. I told you the difference between hematemesis and hematemesis. And you have to, because your clinical presentation in the emergencies is very important to do the differential diagnosis between hematemesis and hemoptysis. এটা স্টমাক আছে এখানে, দেখে নাও, হাত নেড়ে দেখে নাও, এখানে রাখা আছে, দেখে নাও, ভালো করে হাত ধুয়ে নাও, আধ ঘন্টা দেখো, স্পর্শ করো। প্রেম 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 শুধু মোবাইল ভিডিও কলে হবে না। At times you have to feel, touch. Similarly, এটা ভিসারার প্রতি প্রেম, ডেড বডির প্রতি প্রেম। হ্যাঁ, touch, feel, and win the show. Pass out with 60, 70, 80%. Thank you.